Okay, welcome everyone. Thank you for joining us this evening. My name's Darren, and I'm one of the Registrar advisors for GPRA. If the QR code doesn't work, Anchal, you can just type in that URL and you'll get to the same page. That's fine as well. Thank you for letting us know. We'll look into that. All right, so we'll kick things off. If anyone's joining in, can I just ask you to mute your mics, and we'll take questions at the end. I'll kick things off with the acknowledgement of country. So GPRA acknowledges the Kulin people, the Aboriginal owners of the land on which the GPRA office is based. I also acknowledge that we have registrars joining us from all across the country. And so I would like to acknowledge the traditional owners and custodians of those regions and pay my respects to the elders past, present, and emerging. So my name's Darren. I'm one of the two GPRA registrar advisors, and our registrar advisors is Sama. So I am a practicing GP. I work as an academic at Macquarie Uni, and I was previously training under GP Synergy, and was an RLO with GP Synergy as well. So today, what we will be talking about is two kind of main topics. One will be around practical tips navigating the general practice consultation. And the second half will be talking a brief overview on billings and commonly used and overlooked item numbers. So it's quite a lot to cover today in the 1 hour that we have. So I'll try to move quickly, but not too quick. If you guys have questions, probably best to type it in the chat or leave it to the end because there is some time at the end for questions. Okay, and the webinar is also recorded. So if you wish to view it again in the future, that's fine as well. Just a quick disclaimer. So GPRA, so we're not kind of lawyers or accountants or financial advisors. So, you know, Zara and I are both GPs. We're passionate about registrar advocacy. And so that's our background, our role. So just a disclaimer that we can't really provide any professional, legal, accounting, financial, employment advice. And if you want to seek professional advice, then you should from the professionals. Okay, you can read our full disclaimer on the website on that URL there. Okay, so let's get into it. So the first half of the talk is to talk about practical consultation tips for registrars, and a lot of these pointers have been adapted from this really great article by Simon Morgan, he's a GP in Newcastle. It is an article in the AFP now called the AJGP from 2014. The link is there below. But it really is quite I thought it was really useful article, and I'll basically go through a little bit of a summary of it today. But it's important to contextualize that, general practice itself is not easy. And so that's why it's quite challenging. And so, it's important to talk about consultation skills because navigating the general practice consult is quite different to, for example, navigating a consultation you may have in like a hospital environment. And many of you may have transitioned from a hospital to a practice environment recently if you're newly starting general practice training. And general practice sees a lot of unfamiliar and undifferentiated presentations because, it's such a got such a wide scope and varied presentations. And there's also this relative independence of decision making. You kind of take it out of that team-based environment where you have like interns, registrars, consultants, multidisciplinary teams into this one-on-one setting with the patient where you have this relative independence that you're making all the decisions. And there's also, of course, as we all know, much greater time pressures and also a lot of clinical uncertainty surrounding the general practice consultations and general practice in general. Okay, so it's important to keep that take those into account, into the context and that we're practicing in. Allude to a bit of a summary on the tips that we'll talk about today. These 9 tips, these are kind of the main headers, and then I'll go through each one in a little bit of detail. But I'm not going to harp on each one for too long, because then, we'll be talking for like 3 hours. Okay, so the main headers are preparing for the consultation, connecting with the patient, identifying the patient's agenda, examining the patient, managing uncertainty, explaining the problem, forming a partnership management, and following up safety netting, and lastly, time management. So the first tip is about preparing for the consultation. And this may seem kind of pretty common sense and intuitive, but I think, as you get busy, or if you're tired, or having a bad day, sometimes you can forget to do this, or you may not think to do this, and that's okay. But it's important to just check whether you've seen the patient before, review their last visit, and so, do all this before you call the patient into the room. And that way, don't make it seem like, if the patient's coming in to discuss a certain result, don't ask them, oh, what are you in for today? Because you kind of already know, like, well, we're here to discuss the results of the tests that we talked about ordering last week, for example. Okay. And the last thing about preparing for the consultation is something called housekeeping. And so that's making sure that you take a break after a difficult or emotional consultation, because you don't want to bring the emotions or any kind of transferring emotions from your past encounter to your next one. So, if you had a really challenging or difficult consultation, it's very important that you give yourself 1 or 2 minutes, taking a physical break. So going to make a cup of tea or something, and then just using that time to do some housekeeping mentally, and then start your next consultation, trying your best not to transfer the emotions across. Okay. So that's number 1, preparing for the consultation. The second tip is about connecting with the patient. And this is generally talking about letting patients talk interrupted for the first minute. So, a lot of some people call this the golden minute. And so if there's been some really good studies that doctors actually tend to frequently interrupt their patients after only a very short time, like less than 20 seconds or something. But there's actually quite a lot of power in silence, in particular, especially in that first minute, especially for a patient that you maybe never have seen before. And, you probably will get most of the core, what they want to tell you about in that first minute if they're left to talk uninterrupted. You can actually try and time yourselves and do a little bit of experiment. It's actually quite hard to not interrupt the patient in the first minute, especially if you're having a very, very busy day. But it's good practice to have, because it actually saves you more time down the track. The other thing to talk about is the use of appropriate expressive touch. I mean, this has been found to improve interactions between GPs and patients. So, obviously it has to be appropriate, hand or forearm or shoulder, for example. You will have to gauge the situation to determine what's appropriate. Generally, if the contact is appropriate, then this actually improves the doctor-patient communication and the rapport between the patient and the doctor. And then the last thing to talk about in connecting with the patient is avoid being distracted by the computer, which is almost practically impossible to do. But rather than just turning back and forth between the screens, you may want to kind of take time out to read a letter or write your notes or look up results. And so this might be, just signposting with the patient saying, look, just excuse me while I write some notes, or just excuse me for looking up some of your previous results, or this letter from your specialist previously. Okay, and so that actually helps to build the rapport and create an environment of patient-centeredness as well. Okay. So that's number 2, connecting with the patient. The third practical tip was around identifying the patient's agenda. And so this acronym that we use, and you'll hear about a lot, especially if you're kind of leading towards studying for your clinical exams is to ask the patient about their ideas, concerns, and expectation, and we use ICE as an acronym. And so this is about the notion of identifying the patient's ideas, concerns, and expectations as a key element of trying to understand why they're here to see you today, right? So, the patient's ideas, for example, is what do they think is going on? And to ask what concerns, you may ask something like, what are you particularly worried about or concerned about? And to gauge your expectations, you may ask something like, what were you hoping to get out of this visit today? And that's actually really good because it helps to make sure that the patient's agenda and your agenda kind of meet in the middle or balance out, and that you're on the same page. Because you may be surprised that sometimes patients are just like, oh, I just wanted to get a medical certificate or something because I don't want to go to work, and then you might be thinking of something else completely, like or should I order some tests or this or that. Also then, because hidden patient agendas are very common, and so you may want to include a question that tries to elicit any hidden agendas. So this could be something like, is there something else you wanted to address in the visit today? Because sometimes you may find that hidden agendas emerge later in the consultation. So you classically get these patients that come in and they're like, oh, I'll talk about this and that. And then, you're like 20 minutes in your 15-minute consult, and then at the last part, oh, by the way, I've got this, chest pain or something. And so trying your best to identify the patient's agenda early on in the consultation can actually be both helpful in terms of building rapport, but also increase your kind of efficiency as you get through your day. So another approach you can think about is, once you're finishing up with your consultation, you can ask the patient something like, you have come in today with certain concerns and expectations about what you want to get out of today's visit. Do you feel that these have been addressed, for example? And that way you can always kind of make sure that you're on the same page in addressing the patient's agenda. Anecdotally, so hidden agendas is probably more common in teenagers, middle-aged men, and patients who are elderly, but really they can happen in any patient and patient group. Now, the fourth one is examining a patient, which seems pretty straightforward, but again, all these things tend to kind of get lost as you get really busy with your day. And there have been studies that show that, over the recent years, there has been a decline in the physical examination skills of doctors in general. But as a registrar, I think, especially if you're studying for exams and things, this is probably you're still going to be doing this very well. But because once you kind of fellow and finish your exams, and finish your training, no one's there to watch over your shoulder, watch over your back anymore. And so you have to be make sure that you don't get too comfortable, and make sure that you always examine the patient routinely, and always examine your focus examination, and you have to make sure that you expose the patients adequately. Especially for like respiratory examinations or joint examinations. And, also then, when we talk about exposure, then you may want to also talk about appropriately using chaperones, for example, okay, to reduce your risk and medical legal risk as well. All right, so that's number 4, examining the patient. Number 5 is talking about managing uncertainty, which is really, really, really huge thing in general practice and kind of primary care. And I think many registrars early on, and also I guess even now as a fellow, you might find this challenging. I mean, there are a number of ways that you can help to increase kind of your proficiency in managing uncertainty, because that's really an essential skill for GPs. But there is always going to be uncertainty forever when you practice as a GP, and so that's part of general practice. So some practical strategies is obviously seek information routinely. So there's lots of really good resources now, up to date ETG, all these kind of resources that help to summarize evidence and guidelines, and you can look at these during the consult, and even sometimes you can just tell the patient like, look, let's look up on the latest evidence or guidelines on this and that, and you can look it up together. Obviously you can always ask, you should ask your supervisor about any things that you're unsure about. And also you can use Murtaugh's kind of diagnostic framework as well to help manage uncertainty. So ruling out the things that are really bad or red flags. The other one is talking about using a diagnostic pause. And so this is essentially what is described. So taking a pause in the consultation, or maybe after you've finished your consultation, to just digest all the information again and see that whether any new kind of diagnostic pathways open up in your mind, for example. And so, like, for example, like when you're washing your hands, or like, making a cup of tea, you can reflect on your current working diagnosis. Using watchful waiting. So sometimes you may need to use time to wait for other symptoms to declare itself. And you can do that, and that can be done safely. Obviously ordering tests and investigations judiciously, rather than using, a scattergun approach and ordering every single test or CT, chest, septal, pelvis, and brain for every kind of undifferentiated presentation. So using kind of discernment to order your tests is going to be more useful than scattergun approach when ordering your tests. The next thing is talking about listening to your gut feelings. And so, if you have a sense of unease or alarm, even in a setting of, for example, a very unremarkable clinical presentation, then the general rule is that you should act on this by seeking the appropriate advice. So this may be just kind of, flagging it with your supervisor or discussing the case with your supervisor at the end of the day, going, look, I feel a little bit uneasy about this case, although I can't really put my finger on it. Everything seems fairly benign, but I just wanted to discuss the case. And it's always good to get, a second set of eyes and brains on it to talk it out and see whether you've missed anything or anything else should be done. And the last thing that we use a lot all the time is safety netting, obviously. And this is about, setting appropriate follow-ups, giving appropriate advice on red flags, and managing kind of how you want to follow up with the patient in the future. So that's about managing uncertainty. The next practical tip is about explaining the problem. So again, this seems really obvious, but sometimes we can get to a diagnosis in our head and then go straight into kind of like investigation and management. And then we forget that we've not actually explained what we think is going on to the patient. So it really is about telling the patient what you think the working diagnosis is and explaining it to them kind of in a language that they would understand. So that's before kind of you start printing out while you're printing out all your blood test forms, or maybe printing out your scripts, you can kind of give a quick summary to the patient, saying something like, so after taking a history and doing the examination, I think the most likely working diagnosis is this or that. So even if you're uncertain what the diagnosis is, or if the diagnosis is fairly undifferentiated, it's important, you can still describe like what you can reasonably exclude from kind of your range of working diagnosis. So you could say something, well, at least we can know it's highly likely not going to be this because X, Y, Z, A, B, C, for example. And I think sometimes this is where kind of miscommunication happens, and patients come out of a consultation going like, oh, I still don't really know what I have, or for example. And this is where you come back, circle around to addressing the patient's agenda. So, and that links to, first, obviously you have had to identify what their agenda is in order to address it towards the end of the consultation. Okay, so that's number 6 about explaining the problem. Number 7 is about forming a partnership in management. And so this is really about shared decision making, which is again something that you'll obviously hear and be talked a lot about throughout your registrar education and training. And this really is all about involving the patient in the decision making process in terms of their management. So obviously we want to involve patients in discussing their management, and one practical way you can use to reinforce a partnership approach is to use plural pronouns such as we and our, for example, when discussing management plans. So you could go like, so these are our options for management 1, 2, 3. Like, where do you think we should go from here? Or what do you think we should do? Or what would you like to do, John, for example? So using these kinds of language to facilitate shared decision making and forming a partnership when you're talking about management. All right, so number 8 is about following up in safety netting. So we talked a little bit about that in managing uncertainty, but really this is about arranging appropriate follow-up for patients being an essential element of the consultation, right? So try to be more explicit about follow-up plans, because I think sometimes that's where things can be a bit vague, especially for newer registrars. So rather than saying, or if the symptoms get worse, come book an appointment or something, you might say like, if your temperature goes above 39, please book an urgent appointment. Or you might say, come book an appointment to see me for a review in 3 days, and tell them, rather than saying, come back and see me if you're not better or something. So generally, I would encourage to just have a low threshold for getting patients back for review, especially if you're early career GP or early on in your training, because that's fine. Patients, unless a patient is telling you like they don't want to come back, generally most patients will be acceptable of this, and it's generally good practice. And as you go along and your experience grows, then you may decide to change it. But also, if you're concerned about the patients, you can phone them, and now you can kind of now there's an there is ability to bill for your time phoning patients, with the new telehealth item numbers. Okay, and definitely safety net patients of concern, especially in context of like undifferentiated presentations with the potential for serious illnesses. So that might be like, febrile child, or patients like with increased risk of complications, such as older patients or patients with multiple comorbidities, for example. All right, and the last practical tip is about time management. So time management is always very hard, especially if you're starting out as a new registrar. Learning about everything else on top of trying to manage your time. Some of the more practical things that I can, tips that I give you is, is to know the value of identifying and prioritizing a list of problems early on in the consultation. Okay, so don't wait till the end of the consultation to start doing this, but as soon as the patient is finishing up their golden minute, you should be kind of having a list in your head about these are issue 1, issue 2, issue 3 or something that we need to address. And then you need to prioritize them in order, which is most important, that you think is most important, but then you also need to prioritize and ask the patient what they think is most important for them. Generally, then you emphasize that the 2 most important problems on any list of complaints are going to be the top priority on your list as the doctor and the top priority on their list as the patient. Hopefully they're the same thing, but if they're not, then that's okay. But you have to focus on those 2. And sometimes the list might be so long that you're not going to be be able to address everything in that one consult, okay? And so with the beauty of general practice is that you do have the ability for longitudinal care with your patients, and you can ask them to come back. And so you could tell the patient, look, this is, you have 5 or 6 issues we wanted to discuss today. We've identified that issue A and issue B are going to be our top priority, and we're going to spend our time talking about that today. But I think for the rest of the issues, we're going to need you to, we will need to address it over multiple visits over the next couple of weeks or something. And most patients are okay with that, and they understand that you're not going to be able to cover everything in like your, 15 or 30-minute consult. All right. So that's my first half on practical tips for consultations. The next bit, I'll move on and talk about billings. So what I'm going to talk about is going to be quite brief, and I guess I could talk about Medicare schedule and billings for like 5 hours, but that's not going to be very exciting. But generally, I'll just talk about, commonly used items, some useful resources that you can use, some commonly overlooked item numbers. Some of these terms you may have heard of or read about: 80-20, 30-20 rules, the PSR, and then very, very briefly, Workcover, DVA, overseas student health insurance and stuff, which is outside Medicare, of course. And then we'll have some time for questions at the end. Okay, so this slide is about some useful resources. So obviously, the whole Medicare benefit schedule is online, and it's the mbsonline.gov.au kind of website. And so you can literally search any item number and look up what the exact descriptor is on the Medicare schedule. All right. And to couple with that, if you have any kind of difficulty interpreting what that item number means or describes on the schedule, or whether you can claim that item number for particular visits or something you're planning to do, there is the Ask MBS email advisory line or email. And that's the email there, askmbs@health.gov.au, and you can pose that question to them. I have asked them a few questions before. They take ages to reply though, so just be prepared. It's a bit of a wait time on the response, okay? I'm sure many of you may have seen this, but the AusDoc MBS Quick Guide is a really, really useful reference cheat sheet on all the very commonly used item numbers. And it's updated monthly. So that's the link for the guide that was updated for May. And they have one for all the new COVID telehealth item numbers as well. And it looks something like this. You may have some practices use it and stick it in their consult rooms and stuff, but it's really useful. And it's really useful for you to reference, especially if this is all new to you. It's split into kind of attendance item numbers in the green part, your health assessments in the gray, all your care plan CDM item numbers in the blue, mental health item numbers in pink, women's health in red, and then all your kind of minor procedures in orange and diagnostic procedures in the olive color at the top. So that's very useful, and really these are going to be a lot of the item numbers that you would commonly use. I'll talk about a little bit more about the most commonly used attendance item numbers. So these are your level A, level B, level C consults. So your item number 3, 23, and 36. The thing I wanted to point out for these item numbers, especially your 23 and 36, probably going to be the most common ones that all of us are going to use, okay, so these are the descriptors of these item numbers when you look up on MBS online. And really, the descriptor for item number 23, so your level B consult, is a professional attendance by a general practitioner at consulting rooms lasting less than 20 minutes and including any of the following that are clinically relevant. So taking a history, performing an exam, arranging necessary investigations, implementing a management plan, and providing appropriate pertinent healthcare for one or more health-related issues with appropriate documentation. So I mean, the key things here is that difference between a 23 and a 36 is literally the time. Okay, so they don't necessarily have to have a more complex presentation for 36, or you don't have to have 2 issues to build a 36. It's literally the time. So the descriptor for 36 is exactly the same, but the attendance has to last at least 20 minutes. Okay, and you can see I've put them in boxes there. And again, it has to include any of the following, so it doesn't have to be all. It's not all of the following, so you don't have to do all of A, B, C, D, E. Obviously, you have to do what's clinically relevant and document appropriately, but it doesn't mean that for every patient they have to be A, B, C, D, E all included. All right, so it's any of the following that are clinically relevant. So that's just to take note. And so, literally the difference between the 23 and 36 is the time. So if your consult was at least 20 minutes, that's a 36. If your consult is less than 20 minutes, that's a 23. Okay, so that's something to take note. So it's quite useful reading up the descriptors if you've never read them before for various item numbers, because then you actually know what you're claiming and what they say. Okay. Now the other thing I wanted to talk about was claiming attendance item numbers. So that's your 23, 36 together with mental health item numbers. So for example, can you claim level B 23 and a mental health treatment plan? And I think there's quite a lot of kind of talk about this over the last couple of years. But essentially, you can claim these item numbers for the same visit, but as long as kind of it has to be unrelated issues. So for example, if you spent 25 minutes discussing a mental health treatment plan for a patient, and then you subsequently spent kind of 10 minutes talking about a musculoskeletal, like they sprained their ankle from playing soccer and someone tackled them last night, and you had to talk to them about management, maybe you did some wrapping, or you gave them some prescription kind of anti-inflammatories and whatever, maybe you sent them for an x-ray or something. So the key thing here is that the two things have to be unrelated. And when you submit your billing to Medicare, you have to annotate that these item numbers are unrelated to each other. And you have to ensure that you document very clearly the separate issues at hand, okay? So depending on the kind of software you use, this may look like just writing issue 1, issue 2 in the same note, or you may want to create a new kind of patient encounter and one for the mental health treatment plan and then one note for the other unrelated thing, okay? So you can claim for these together, but they have to be unrelated issues. That's the main thing. All right, and that's where all the controversy lies, I guess. The other big area to cover is the chronic disease management item numbers. Often this is about care plans and team care arrangements. So you can see here, these are your kind of main CDM item numbers that you use and the minimum claiming period. So, I'm sure all of you know that it's an annual claiming period for a GPMP and a TCA. And then for your reviews, it's every 3 months. I think something people don't commonly know is that you can actually bill for a review at less than 3 months if there are exceptional circumstances arising from a significant change in the patient's clinical condition, all right? Or there are care circumstances that necessitates earlier review. So for example, if you just did a care plan review for your patient last month, but then they had a stroke and they ended up in hospital and then they got discharged, that is an exceptional circumstance and there's a significant change in the patient's clinical condition. And so you can organize a care plan review at less than 3 months from when they come out of hospital. All you need to do is that you need to annotate and when you're claiming billing to Medicare, when you're submitting the claim to Medicare, to indicate the reason why. So you can say, patient had a stroke and significant change in clinical condition or something. And so that's fine. And the way you annotate these things, it depends on your practice and what kind of software you use. If you don't know how to do that, you should talk to your practice manager or supervisor on how they do these things. It's going to vary depending on like the software you use and your practice that you're working at. Okay, so that's the thing I wanted to note in terms of CDMI numbers. Otherwise, the rest are pretty straightforward. I think most practices are pretty on the ball with kind of claiming CDM item numbers because, you know, that's where a lot of their income will be generated from. And so in the future as well, CDM item numbers are going to be kind of what generates the most income for you if you go out and work as an independent contractor. So it's important to know the rules and how to claim these item numbers properly and appropriately. Okay. All right. The next thing was to talk about the multiple operation rule. So the multiple operation rule is mainly for procedural item numbers. And this is where, like, if you're doing multiple procedures on the same patient, for example, or claiming multiple procedural item numbers on the same day. So for example, let's say you did a skin check on the patient and then you like punch biopsy 3 a bit sus moles or something. You won't get paid for 3 punch biopsies, okay, because of the multiple operation rule. So you'll get paid for 100%. So I think a punch biopsy, a 30071 is like 50 something. Let's say it's $50. It's 50 something dollars, but let's say it's $50. So if you do 3 punch biopsies on the same visit and you're claiming 3 times the 30071s, then what you'll do is what you get paid is you get $50 for the first one. For the second one, you get 25, and then for the third one, you get 12.5. So you just add that up. That's what you'll get. And so that's how the multiple operation rule is used and calculated. Okay, so just be aware, I guess, if you're kind of someone who does a lot of procedures or biopsies. All right, moving on. So commonly overlooked item numbers, I mean, these are all actually in the OSDoc kind of MBS quick guide. But these medication review item numbers, I think, depending on the practice you work at, like some practices might be really good at it because they have a really close relationship with their local pharmacies. But these can be claimed annually, and it's actually kind of a lot of the work is usually done by the pharmacists. And so there are templates out there on how to do these, especially if you use like best practice. There's a template on there on like what to fill in, and then you send them to the pharmacist, and the pharmacist actually does the review with the patient and then sends the report back to you that you need to discuss with the patient, and then you can claim this item number. I think not many people know about it. I certainly didn't know about these things when I started training as a GP registrar. But if you wanted to know more about it, you can read it up. Go to the MBS online website and then put in item number 900 and read it up. So 900 is for patients who live in the community, so in their own houses, and then 903 is for patients for living in residential aged care facilities. Okay, the rest of these item numbers are just things that you probably should kind of remember to bill them if you're doing them in your consult. So if you ever get someone to do a urine pregnancy test, you can actually bill for it. I think it's an extra like 10 or 12 bucks that you get. If you do spirometry, make sure you bill it in your practice. If you get someone to do you get your nurse to do an ECG, and you looked at it, then you should bill it. Some practices have the ability to do 24-hour ambulatory blood pressure monitoring. So you should bill for it, okay? If you kind of stick a scalpel into an abscess in drainage, there's an item number for it, and you can drain it, okay? So that's commonly overlooked item numbers. Now, the other things to note are then, what is these 80-20 rules, 30-20 rules? So basically, these are what has been termed prescribed pattern of service rules. And the 80-20 rule is if you have kind of rendered 80 or more professional attendance services on 20 or more days, on each of 20 or more days in a 12-month period. So what does this mean? This means that like you saw 80 patients or more each day for 20 days over a 12-month period. So on average, like every month for 2 days, 2 days a month, you're seeing 80 or more patients. Like if you do that over a 12-month period, you will get flagged. But that's like a lot of patients. So if you're seeing like 80 patients a day, that's a lot. You should review your workload as a registrar. Okay. I don't think many of you will hit these numbers, you know, but this it's going to be quite hard to hit that number. What's a little bit more anxiety provoking was when they introduced the 30-20 rule for telephone consultation item numbers. And that's the same kind of principle, but 30 or more telephone services on each of the 20 or more days. So that shifted to then practices defaulting to using video telehealth more than telephone item numbers. So again, if you're using a lot more video now, hopefully it's quite unlikely that you'll hit these numbers. Okay, so the what they've done is that they've put in these rules so that they can flag people who are claiming really high volumes, and then they will flag you for review if you breach these rules, and then they will go into a determination on whether you'll be referred on to the PSR. So what's the PSR? The PSR is the Professional Services Review Scheme, and so basically they're kind of like this committee or team of people that go and kind of investigate or audit people that have been referred to the PSR to determine on whether they've kind of claimed item numbers inappropriately. Okay, so the PSR will come and find you if you breach the 80-20, 30-20 rules and they've decided to refer you to the PSR, or if they identify any unusual patterns of item usage or item combinations. If you are ever contacted by the PSR for whatever reason, you should always call your MDO first and seek advice from them. I've never been contacted by a PSR, so I can't tell you what the process is like, but it's definitely, from reading a lot of kind of articles, it's very stressful. I don't think it's something you want to go through if you can avoid it. A general rule is to document. So be concise and comprehensive in your documentation. And that's going to be a good defense for you, regardless of what it is. If it's a medical legal thing, if it's PSR or whatever, because people are going to refer back to your notes and what you've documented. All right. This includes like your care plans, what you write in them, correspondence, and also obviously your notes. Okay. All right, the last bit was about Workcover, DVA, obviously student health cover and stuff, and then I'll get to your questions. So just to note, I'm not going to talk about any of them in detail because then we'll spend another 3 hours talking about each of these. But just general, these are not things that are built under the kind of the MBS, the Medicare schedule. Workcover is its own thing. So, for those of you who have seen Workcover patients, there's like specific paperwork. You have to fill in a certificate of capacity. You have to make sure that you get the claim number. Sorry, you have to make sure you get the claim number from patients for your Workcover claims. DVA also sometimes have their own specific forms. And if you are working in a place where you see like international students like me, then these students are generally not covered under Medicare, but they're covered under kind of insurance companies like Bupa and NIB or whatever. So most of these insurance policies essentially mirror the Medicare schedule, but instead of being paid by Medicare, like the students are rebated by their insurance company. Okay. All right. And so that's all I had. I will start answering some questions. Let me see. So I'm just going to put disclaimer, like I'm not the Department of Health. So if you have very specific questions on like whether you can build certain things, I may not know the answer, okay? And you may want to check with Ask MBS or check with your practice supervisors and managers. Okay, I will start with Rebecca's question. 721, 723, 12 months from Jan to December, or 12 months when the plan is complete. So to my knowledge, after having claimed a lot of these now, I think it's 12 months from the date when the plan is completed. Okay, there is a way to check whether a patient, whether you're eligible to claim 721 or whatever item number on PRODA. It's a bit complicated to get to that page, but if you want to know how, you can email me and I can show you. But there is a way to check on PRODA. I hope that answers your question, Rebecca. HA, same as for mental health. Yeah, so it's the same. To my knowledge, it's not the calendar month, but it's 12 months from when the last one was done. Okay. Can a procedure item be claimed with a normal consult? So I'm assuming you mean the attendance item number if a patient has another issue to be treated. So I think that's okay. So I do that. So if someone comes in and they were like, I need to talk about, I don't know, like I've been having headaches or something, but then also then said, oh, can you look at this mole? And then I looked at it and I'm like, oh, I think we should biopsy it. And I do the punch biopsy. I'll claim the 23 or the 36 with the 30071, for example. So yes, but I think you can't do that if you kind of specifically ask the patient to come back for an excision, for example. Or you've asked them to come back for the specific procedure only, and the appointment was made for a procedure, then I don't think you can claim both the attendance item number and the procedural item number. There are some procedural item numbers where you're not allowed to co-claim with an attendance item number, but I don't think any of those generally you'll come across. If Mary's question, if you're doing mental health care for someone with depression and also want to do general bloods, would that be considered unrelated? I mean, yeah, like an organic screen is related to your mental health consult, so I would consider it related. I guess the answer to that question, could you argue either? I guess so. I mean, you can bill whatever you're comfortable with. I wouldn't bill that separately. I would bill that under mental health, because ordering an organic screen as part of someone with newly diagnosed depression is going to be part of your mental health workup. If 47-year-old male was seen a month ago for 49, can we still see it? Ivan, I don't know the answer to your question. Sorry, you'll have to look it up on the MBS online website, because I can't remember off the top of my head what the details of those are. Minga's question, 80-20 means 80 patient, 80 items. It's 80 items, but I'm assuming it's going to be equating to 80 patients because, I mean, unless you're seeing someone twice in the same day, which is quite unlikely, if you're claiming 80 attendance item numbers, it's going to generally equate to 80 patients. But the rule is 80 item numbers, okay? That's the rule. It doesn't count patients. Can we bill a skin check and biopsy at the same time? Well, there isn't really an item number for a skin check. So, Catherine, I think you may be meaning like attendance item number. Again, I think that's fine. Yep. Again, disclaimer, I'm not the PSR or Department of Health, so you have to take all my advice with a pinch of salt. So there was a message from Katrina. Can you comment on script requests? Patients calling, asking for a script, and also when pharmacy sends through lists of scripts or Webster packs on nursing home patients. So the way to manage this is you bill for a telehealth consult. Okay, so you either tell the patients that you'll call them back, and then that this will be, billed under Medicare, and you however your billing practices are your practice, whether you charge a gap or you bulk bill that's based on your practice. When pharmacy sends through lists of scripts for Webster packs and stuff, it really depends on your practice policy, right? So you obviously don't want to be doing work for free. So, if I've worked in practices where they're made to have appointments to sort these out. And so we will bill for those appointments. Okay, I've worked in practices where they have kind of an online kind of script renewal thing where the patients pay a fee of like $20, and then they can kind of go through an online portal and get their regular doctor to review the script and send them an e-script. So it really just depends on what your practice is like, Catriona, but definitely you should try to bill for your time of doing this work. And there's multiple ways that you can do that. Ricky's question, thank you so much for great info. I wonder if you know phone consult for DA need to meet the pre-existing. I don't know the answer to that, Ricky. Sorry. We might have to look that up. How we're gonna be team care arrangements roll over every gen. Yeah, I've heard both sides. To be honest, I claim all my TCAs and GPME reviews every 3 months, so it doesn't really matter that much whether it rolls over in January or not, because by that time, generally, either in January, February, or March, I'd be claiming a new one anyway. All right. So now this question, if a patient is booked for mental health care plan review on the day and has a medical issue as well, does it matter? No, the order doesn't matter, Sonali, as long as you document it correctly and you annotate in your billing to Medicare that is unrelated issues, okay? Swapna is a question. Some patients tend to talk tangentially about the previous consults, their life, which takes a lot of time. How can we tackle these without hurting the expectations and listen to them? Yeah, it's tricky. I think it's you develop your own style over time, Swapna. It's hard. I think as you see these patients more, you probably develop a rapport with them. Sometimes you find like, once they see you once or twice, they kind of have told you their story. They tend to talk less as they go on. But it's hard. There's no real kind of easy way other than to gently redirect. And the way that everyone does that is a little bit different, and it depends on the patient as well. Okay. My understanding of excisions biopsies was the item was held until histopathy available and you bill based on result. If you bill to result 7-1 at a time taking biopsy, can you now bill? Yeah, so Jack, that's correct. Okay, so if you're doing a punch biopsy and you think that you may want to do a kind of complete excision afterwards, then you should hold the billing to see. You're right. If you build a 30071 at a time of taking biopsy, I don't think you can build a histopath specific item later, because there'll be double dipping. If you work in kind of like a clinic, there's a lot of skin work, ask the doctors that do the skin work and they'll tell you how to bill it correctly and most efficiently and most value for money way. How do we get credential for 4001? What's 4001, Ivan? I don't even know this. Can it be billed with saying there's anti-nail? I don't know the answer to that question, Ivan. These very specific questions. Sorry. I can collect them and ask someone. Oh, but Ricky has answered. Awesome. Thank you, Ricky. Okay, thank you guys for answering those questions on my behalf. All right. So does anyone else have any more questions? I hope that was useful. And I realized I didn't write my email in there, but I'm going to type it in the chat. If anyone has any further questions, you can email me. That's my email address there. Oh, and yes, I need to spruik GPRA. So it's free to join GPRA. I don't know if this QR code is the same dodgy one that doesn't work. But if the QR code doesn't work, go to that link below. And there's lots of resources there for you. The webinar is recorded, Minga, and it will be made available on our GPRA YouTube once we kind of consolidate it. Okay, thank you very much, everyone. I will leave you all to enjoy your evening and good luck with training. If you have any further questions or want to talk about kind of Anything else, you have my email address and you can email me there. All right. Have a good night.